Doctor, you beautifully explained how you can spot a donor for our viewers. So, Doctor, let's also cover a bit of topics for our viewers. Could you just help us understand, the people who are right now have a higher cases of hypertension, obesity, and diabetes. Is this anything correlated to a lungs diseases as well?
Definitely, that's a wonderful question actually. No, of late actually probably because of the stress in life actually, with undisciplined day-to-day activities in terms of junks, oily food, excess of sugar, carbs, and sedentary lifestyle. All this thing adds to one risk factor for obesity. Now, invariably, obesity comes with sort of a airway compromise also, where we come up with an entity called obstructive sleep apnea, where the windpipes are getting choked. Predominantly, when we have a voice box or a vocal cord, below that is a trachea, which is very well protected by cartilage. But unfortunately, from the nose to the vocal cord, there are a lot of soft tissue, including a tongues and a laryngeal muscles. Invariably, when you tip into sleep, there is a stage in sleep called REM sleep, rapid eye movement part of a sleep, where there will be relaxation of muscle causing oropharyngeal relaxation of muscles causing choking like of an episode. Just this sort of an episodes can trigger a sympathetic drive where sudden increase in heart rate and blood pressure do happens on a recurrent cyclical way. Once the patient get awake, the sympathetic drive goes back to normal. This sort of a repeated interruption of sleep leads on to a diagnosed diabetes or hypertension. If not getting controlled, definitely there will be high risk for developing any sort of a stroke or cardiac dysfunction in the future day to come by.
So, viewers, for your discretion, if only you're having a shortness of sleep or shortness of breath while you're sleeping, do not think it's a very normal. Please visit your nearest pulmonologist for a consultation to examine whether you're suffering from sleep apnea. Doctor, let's moving on to the next one, how the artificial intelligence, which is a very common topic of today's time, how it has transformed the field of medicine, especially in the interventional pulmonology. From early detection of lung diseases to assist the complex bronchoscopic procedures, AI is beginning to change the pulmonologists how they diagnose and treat patients. To help us understand this fascinating intersection of technology and medicine, we seek your opinion on the evolving AI penetration into pulmonology. To begin with, could you explain with artificial intelligence what it means in the context of healthcare and pulmonology?
That's the future of healthcare. Technology is moving at a lightning pace. Unless until you go in parallel with that, definitely will be left behind in the race of how to get your patient a best quality care. Now, when it comes to AI, nothing but is a way of smartly teaching the computer to learn from the existing vast medical data which is existing and try to pick up the salient points so that we are making a computer smarter person in terms of reproducing the same amount of information in a consistent way. If somebody picks up lung nodule, it can be a TB or it can be cancer. Can we train the machine to learn this art of how to dissect these two things and be consistent? Even in night, 2 o'clock, 3 o'clock, they should be in a position to give accurate results based on what are the information what has been fed. Where this comes as a handy options in terms of how to improvise our decision making and also prognostic of this sort of a patient so that the care can be precise and to the point of treatment outcomes.
So, why AI is so important in pulmonology, doctor?
Definitely, if you see the genesis of pulmonology, we always dwell upon two major physiological stuff. One, your imaging modality. Your imaging modality is a specialty where close yourself with AI. At the same time, physiological reserves been mapped by doing a pulmonary function test. Now, these two things gives us an impetus to get into the level where can it be more consistent in terms of interpreting these two things. Imaging, I think probably reading an X-ray or a CT scan, can it be consistent? Now, machine learning, we're putting a lot of immense data in terms of nodules or interstitial lung disease, pattern recognition. If that been fed with a humongous amount of data which is already existing, where we have an algorithm which can be using conventional neural network, have multiple combinations which can arrive at a proper diagnosis which will be easy to analyze and be in a consistent way to deliver the best of the best care. At the same time, interpretation of pulmonary function test, be it your spirometry, DLCO, 6-minute walk, CPET, all these parameters gives a wealth of information about the functionality of the lungs. If have a consistent modality which can give you a result which is very precise, which can predict the overall prognosis of the patients and be a marker for a future follow-up, will come very handy utilizing a AI as a tool which can help in these two aspects of a lung practice.
Doctor, lung cancer is one of the major concerns globally. How is artificial intelligence helping in early detection of lung cancer?
That is a fantastic question. Lung cancer, invariably early cancer, we not only treat the cancer, we think about curative intent. Lung cancer, which is very localized, that can be curative intent either by doing a surgical intervention to knock off, where the 5 year survival as a to the 80 to 90%. That's more welcoming as compared to somebody who comes in advanced stage. Overall, your survival is 10 to 15% for next 5 years. So this enormous divide brings us to the level where how to pick up these lung nodules early. One of the fascinating thing about lungs, if you see that trachea, the major windpipe, divides 23 times before ending into a sac-like structure called alveoli. In between, there's an enormous ramification of windpipes. Now, to reach any place in Bangalore, unless until we are backed up a GPRS with this technology, we will not be in a position to exactly pinpoint the place where we want to. Same thing with your lung nodules. If it is center accessible to bronchoscopy with the first or second generation, high risk, high possibility that you can get a biopsy. When you have a peripherally nodules, which are less than 3 centimeter, less than 2 centimeter, less than 1 centimeter, need a proper path which can lead us to the exact airway to get the biopsy from the abnormal nodule which was there. So AI comes up with, can we map these windpipes so that with using just like a GPS system, can we go into exactly the site of lesion to get the biopsy? Many amount of attempts has been done in the past using a radial EBUS where the yield is 60 to 70%. A robotic bronchoscopy goes the yield up to 60 to 70 to 75%. At the same time, we have a navigational tool, electromagnetic navigation, increasing yield to 70%. Of late, we are into multi-modality approach where we're trying to incorporate radial EBUS with navigation tools to get the yield to the tune of 85 to 90%. Still, it's not 100%. All these thing modalities have been there to streamline the things, accurately map the airway based on nodule, what is size, shape, and what is the growth rate, which driven by AI will have a consistent format based on a pretext whether somebody is elderly, smoking history, or cough with hemoptysis, and any breathlessness. All these things put together get you a diagnostic pretext of much better way when it comes to AI incorporated to your decision making.
Doctor, how is AI assisting in interventional pulmonology procedures such as bronchoscopy?
Yeah, as I mentioned, if you go back to basic of lung cancer, nodules. Nodules definitely accuracy in placing the bronchoscopic forceps to the right place is what determined by all this GPS technology like electromagnetic navigation, robotic with a steady distal bronchoscopic probe, which can accurately put the lesion under biopsy sample. At the same time, we are into a lung transplant where, as I mentioned, more than 200 different types of ILD patterns which are there. Everything boils down to 9 to 10 patterns classically described in this assessing the 200 lung disorders of ILD. Now, pattern recognition is a key. Consistently incorporating this with your PFT in terms of predicting the prognostication of this ILD, how far the patients can be survive without much of a oxygen dependency, how to have the trajectory in terms of lung health. There, AI comes up in terms of predicting all these things in a way where it can be very handy for discussion across the table with the patient.
Doctor, apart from a lung cancer, how does artificial intelligence help in diagnosing other lung diseases?
Like as I mentioned, the COPD patient, what is the predictability of exacerbations? COPD as an airway disease is a progressive disease. Now, somebody comes with exacerbation. More than 25% of lung function capacity drops in one shot with exacerbation. If some of the patient who has a significant drop in lung function capacity, can we pick them? Some parameters can predict like your oxygenation tracking, your any utilization of a non-invasive ventilation if somebody was an exacerbations which has not been put on a non-invasive ventilation. All these parameters helps us to guide what is the pretext of this particular exacerbation in a COPD so that decrease the chance of further worsening of the general condition, financial benefits also in terms of avoiding one hospital admissions.
Can AI help doctors predict diagnosis, progression, or treatment outcomes?
Yes, I think that my talk in the last 5 minutes, I think it reinforced the things that it comes in a big way. Coming up to extrapolate the same data to a lung transplant. When it comes to lung transplant, how do you predict the longevity of the patient? Feed in all the necessary data actually in terms of having coming with a predictive model in terms of how to at least incorporate this AI tools in prognostication with parameters what is available to guide us the future in terms of how to take care of the allotted lungs.
Does AI have a role in pulmonary critical care or ICU settings?
That's a fantastic question, actually. Now, when it comes to integration into intensive care, now heart rate, BP, saturation. These are the most common three things which is monitored in any of the intensive care for any patients who is beat on in on mechanical ventilation or a non-invasive ventilation or oxygen support. Now, definitely when we have a closed loop systems where we have these parameters with flagged with ranges where that can give us a better prediction in terms of tracking them in terms of before getting into our decomposition state, can we pick them early so that the necessary appropriate actions can be taken to avoid untoward mortality also can be incorporated.
While AI sounds promising, what are some of its limitations, doctor, and medical practice?
Fantastic. Now, this is where I think not AI is a rosy picture. There comes the acumen of a clinician in terms of how do you use this sort of a technology to the best of your best capabilities and judgment in terms of what are the limitation. There's a term that is called hallucination. These are the things what we see come with the AI. It all depends on what is the quality of AI data which has been fed into the system. Any regulatory things which is not been clearly documented in this whole picture, then definitely this data has to be driven with a proper understanding of a clinical acumen, not to replace a doctor.
Looking ahead, how do you see AI shaping the future of interventional pulmonology?
Yeah, it's a very promising field actually. Probably in future, because of the work pressures what we have with the volumes what we are building up actually, if we have a regimented structure, we can streamline the whole things in a comprehensive way so that a precision and a better outcome is one which is promising at this point of time with the clinical acumen of a person judging based on that the future of AI also can be incorporated in a better way.
Finally, what's your message you like to share to our young doctors and pulmonologists about the artificial intelligence?
Now, writing on a prescription paper is never an absolute, it is an art actually. Over a period of time, we are transforming that into a digitalization of things, which is the need of the hour. The more proficient, more learning process do happen with the digitalization so that everybody can be in a common platform. Invariably, there's no running away from the situation actually. We need to embrace that intervention pulmonology or a pulmonology practice, be it your healthcare, has to go with matching up with the technological advancement in terms of incorporate AI into our day-to-day activities. So the key point to my young colleagues are try to get tech savvy, digital savvy, so that you will have a better outcome in terms of how to treat the patients in a precise and a better way.
Clearly, doctor, artificial intelligence is opening new possibilities in diagnosis and treatment of lung diseases. While it cannot replace the expertise of clinicians, it can certainly enhance precision and efficiency. If you give three key takeaways about lung health, what would be they?
This is a gist of what we have discussed actually. Please don't ignore persisting symptoms of cough and breathlessness. Early diagnosis saves lives. Dwell upon some of the preventive measures. If somebody smokes, stop smoking. Prevention by vaccination and air pollution control, if there are modalities, are the one which could be the take-home message from this particular discussion.
Doctor, if you can also dive to our viewers about the pollution, how it affects the lungs, and also the what is the optimal air quality index we administrators have to look into to ensure that we live in a healthy city.
That was a wonderful question, actually. Now, I'll just go back to some of the basic physiology of lungs. Now, as I mentioned, trachea divides into 23 times before ending into alveoli. These air sacs are the place where the air exchange do happen outside atmosphere, directly exposed to your alveoli with the oxygen, which transfer into a blood. From the blood, the carbon dioxide will be released in the X-ray expiration. What we do now, invariably in a day, we take at least 10 to 12,000 liters of air goes in and out. Unfortunately, we are not so lucky to get only the pure oxygen, the dust, pollution, whatever there in the vicinity has to be breath in and out. And that too with a sensitive person, with any of the pre-determined hyper-responsiveness or any asthma tendency, they'll be slightly more vulnerable to catch up this sort of a triggering agents to have more symptoms and more exacerbations. Now, you brought up a nice point about air quality index or AQI is an acronym. Normally, we should have it, grade into 50, 100, 150, 400. Now, anything less than 50 is what desirable. If you see an average air quality index across Bangalore, we are hitting at a hovering rate of 130 to 170. Now, invariably, that means there's too much of inhabitations, getting into urbanization, the pollution, air quality also dropping. We can see that alarming rates as it comes to Delhi, we are slightly better off. Now, air quality index, invariably we come multiple or minute particles, sulfur dioxide, ozone, all this part and parcel of particulate matter, which can be a risk factor for somebody to develop airway inflammation when this thing breath into the lungs. Invariably, this inflammation on a chronic nature can cause a sort of a reversible pathology into irreversible lung scarring and damages. Sensitive pattern of a patient determine how patient gets sick over a period of time with a constant exposure to this air pollutants.
Thank you, doctor, for wonderfully explaining that today in the dwelling times what we live in, how important is that we need to put a stop on the pollution and improve the air quality index. We come to the last round, doctor, which is my favorite round. That's the rapid fire round. Even today's doctors are not spared for rapid round. So it's going to be either myth or fact about the lung additions. So I'm going to ask you a quick question. It's going to be a yes or no kind of an answers, and you have to give more information about the question. Please feel to give a deep dive about the answer. All right, doctor. Now it's time for the rapid round. Only smokers get lung cancer.
No, non-smoking lung cancer is to the tune of 10 to 20%. Passive smoking, secondhand smoking, air pollution also contribute for apart from genetic predispositions.
Okay, if I stop smoking, my lungs completely go back to normal.
No, quitting helps greatly, but there are always a possibility a few part get into a permanent damages in the process of quitting smoking.
A persistent cough for more than 3 weeks, should it be ignored? Or if there's no fever?
No, any long-standing coughs needs a proper thorough evaluation to ascertain what is the cause for the abnormality.
Doctor, asthma is always treated as a child disease.
No, most commonly encountered in the early part of your life actually, but it can be presenting in adult life also.
One of the common myths people face is, if I can exercise without difficulty, my lungs are completely healthy and perfectly fine.
No, early lung disease can exist without obvious symptoms cropping up.
Doctor, lung biopsy is a major open surgery.
No, most lung biopsies are today done by minimally invasive procedures using a bronchoscopy.
Doctor, interstitial lung disease or ILD, which is commonly known, is contagious.
No, ILDs are not a contagious disease.
Doctor, if I don't smoke, I don't need a lung checkup. Is it true?
No, pollution and occupation exposures also affect the lung health.
One of the myths in India is lung transplant is rarely done in India.
No, lung transplants have been successfully performed in specialized centers in India.
Using inhalers for asthma leads to addiction.
No, this is the most common myth what patients come with interactions actually. Inhalers are the safe and the essential part of asthma control.
All breathlessness leads to the heart problems.
No, lung diseases are very common causes of breathlessness.
Pneumonia is just a severe cold, doctor.
No, pneumonia is a serious condition that can subject somebody for hospitalization also.
So if my chest X-ray is normal, I can't have a lung cancer, doctor.
No, early lung cancer can always be missed by a routine chest X-ray that needs a proper evaluation before you could say that the X-ray is normal.
Wow, that was really powerful and eye-opening. Clearly, there are so many misconceptions around lung health and awareness that can literally save lives today. Absolutely, early diagnosis and informed decisions can make all the difference. Is that true, doctor?
100%. I do agree with that actually. Informed consent and awareness is the need of the hour, which should be the lightning force in terms of how to take this lung health to the next level so that we can breathe comfortably without discomfort.
So finally, we come. It's so important that breathing is life, and modern medicine can be transformed how we diagnose and treat lung diseases. From interventional pulmonology to lung transplant programs, early awareness makes all the difference. Thank you, Dr. Sunil, for sharing such valuable insights. And to our listeners, if you found this episode helpful, share it with someone who needs it. This is Dr. Girish signing off. Until next time, breathe well and stay healthy. Goodbye.
Thank you.